Good morning. Today we will be discussing the mechanism of action of the commonly used oral hypoglycemics on an MCQ based. The normally used oral hypoglycemic drugs are different classes are there. They are the sulfonylureas. Examples are the glipizide, glyburide, glycoside and glimepiride. Then comes the meglitinides, comes the ripaglinide and natiglinide, and the bigonides, the thiazolidinediones, alpha-glucosidase inhibitors, acarbose, oglibose, etc. GLP agonists, that is GLP receptor agonists, DPP-4 inhibitors. These two are the incretin-based drugs. And the newer category of SGLT2 inhibitors. And finally, bromocriptine derivative cycloset. These are the commonly used drugs. So let's start with a question. Which of the following statement is wrong regarding mechanism of action of the oral hypoglycemics? A. Sulfonylurea promotes insulin release from the beta cells of the pancreas. Second, bigonides improve target cell response to insulin without increasing pancreatic insulin secretion. C. Thiazolidinediones promotes insulin release from the beta cells of pancreas. D. Alpha-glucosidase inhibitors, they produce a reversible inhibition of the alpha-glucosidase in the intestine. These are the questions, and at the end of the session, we'll find out the correct answer. Let us now take the mechanism of action of sulfonylureas. The sulfonylureas bind to the potassium channel, which is ATP-sensitive potassium channel. So here you can see the potassium channel. The sulfonylurea binds to the ATP-sensitive potassium channel, and what happens? This leads on to blockage of passage of potassium out of the cell, so potassium cannot go outside. This leads on to depolarization. Depolarization leads to opening of the calcium channels. Calcium enters the cell, and this will lead on to further steps for the release of insulin. So insulin is released. So this is the basic mechanism. To remember, the sulfonylureas act by attaching to the sulfonylurea receptors. So here you can see this is the ATP sensitive potassium channel. The Ker 6.2 forms the pore of the potassium channels, and there is sulfonylurea receptor is there. Once the potassium entry is blocked, the potassium channels are blocked, potassium cannot go outside, the calcium will enter, and there is release of insulin. So this is how the sulfonylurea act. There are two subtypes of sulfonylurea. One is a SIR1 and second is a SIR2. The SIR2 is again two subdivisions, SIR2A and SIR2B. Sulfonylurea receptor 1 is mostly seen in brain and the beta cells of pancreas. So in the beta cells of pancreas, it is a SIR1 receptor. SIRB2A, that is a type of SIR2, is present predominantly in the cardiac muscles. And the isoform SIR2B is in the smooth muscles. What is the clinical relevance of this? Some of the sulfonylureas have got affinity to bind to both SIR1 and SIR2. Those who bind to SIR2 can lead on to changes in the heart and can lead on to adverse cardiovascular events, especially when the patient develops myocardial infarction. The affinity of sulfonylureas to the SIR receptors are varying. Glimepiride has a lower affinity to the cardiac muscle and so it is not associated with cardiovascular safety concerns. So that is the clinical relevance. So remember this point. So sulfonylureas also has got additional function. It also decreases the serum glucose levels by decreasing insulin metabolism in the liver. So metabolism of insulin in the liver can also be decreased by the sulfonylurea. It has got a milder action on decreasing the glucagon secretion, and also it increases the sensitivity of insulin in the peripheral tissues. So we can basically say that sulfonylurea act by blocking the SAR receptor, increases secretion, but the potassium channel is blocked. This leads on to increase in the insulin secretion. Second, the glucagon secretion also decreased. Third, insulin metabolism is decreased, and it increases the insulin secretion. It increases the sensitivity of insulin in peripheral tissues. So these are the four major actions of sulfonylurea. So the answer which is given for sulfonylurea is correct. Now we go to metformin. Metformin is one of the essential drugs for diabetes. It is not an insulin secretagogue. Sulfonylurea is an insulin secretagogue. Metformin is a drug that increases the insulin sensitivity. So it is an insulin sensitizer. Second, it reduces the hepatic output of glucose. That is, hepatic gluconeogenesis is decreased. So this is one of the very important action. It decreases the hepatic gluconeogenesis. There are different theories regarding how it is being done. So most important thing, it decreases hepatic gluconeogenesis. It has got a mild action in the periphery. It increases the glucose uptake in the muscles. So the glucose utilization is increased by increasing the uptake of glucose in the muscles. And also it decreases the glucose absorption from the intestine. So predominantly you can say it has got three actions. It is an insulin sensitizer. It decreases the gluconeogenesis from the liver, decreases the glucose absorption, and it increases the uptake of glucose in the muscle tissues. What is the mechanism of action? The primary action or the site of action for metformin is in the mitochondria. So that is why the drug takes some time for the action. This action is said to be due to its effects on the lipid metabolism. By the protein kinase signaling is interfered. So defective protein kinase A signaling is the basic reason, and it affects the lipid metabolism via 5'-AMP activated protein kinase activation. So this signaling, what is happening is the AMPK activation. So AMPK is activated by metformin. In addition to the glucose, the metformin has got an anti-tumorigenic effect also. This is partially due to systemic metabolic alterations that are occurring, including reduced insulin availability. So insulin is a hormone that so the insulin availability or the level of insulin is decreased. That may also contribute to the anti-tumorigenic action. In the cancer cells, metformin acts as an inducer of energetic stress. The AMPK driven inhibition of mTOR seems to be the required action for the antimitotic activity. So this is a difficult topic that can be discussed at a later time. So just remember, metformin has got an anti-tumorigenic action, and it is producing by the energetic stress that occurs in the cancer cells. So it's a summary of the action of the metformin. Metformin is a positively charged particle. It needs transport in the liver. So in the liver, the metformin is highly concentrated. because of that OCT, the cation transporter protein 1, that is transporting the metformin, and metformin acts at the mitochondria. So it is a mitochondrial action. So the mitochondrial electron complex 1, there is interference, there is increase in the AMP. It produces activation of the protein kinase, and this protein kinase has got actions in the phosphorylation of other transcription factors, and that leads on to changes in the lipid metabolism. At the same time, this leads on to decrease in the hepatic glucose production, and also here you can see that the pyruvate will be converted to lactate, excess production of lactate will occur, and finally end result will be there is decreased glucose production. So the decreased hepatic glucose output is mainly by action on the lipid metabolism. Hope this point is clear. What you should remember is oral metformin leads to increased uptake in the liver. The liver produces decreased glucose output and produces increase in the lactate. This is the summary of what you should remember.